much, John, for convening that AGM. So it's my honour to introduce Chris Liu to give the PJ Hay lecture. Professor Liu has been a consultant ophthalmic surgeon at Sussex Eye Hospital in Brighton, where he led the National Osteodonto-Keratoprosthesis Service till 2022. He's been at the helm of many national, regional, ophthalmic and medical learned societies and been Honorary Secretary of EUKISCRIS. He is currently Honorary Treasurer of the Royal College of Ophthalmologists, Council Member of BCLA and CQC Specialist Advisor. He has over 250 scientific publications in the ophthalmic literature, many book chapters and 3 books in his name. He was appointed OBE by Her Majesty Queen Elizabeth II for services to ophthalmology in 2018 in the New Year's Honours List. He has been an avid proponent of safe ISBCS for over 20 years and looks forward to delivering the Hay Memorial Lecture on this topic. Chris.
Mr. President, ladies and gentlemen, it's a real pleasure, privilege and honour to be here to deliver the Hay Memorial Lecture. So I've chosen the title, The Truth About Immediately Sequential Bilateral Cataract Surgery, or ISBCS. You've heard a little bit about this already this morning in one of the papers. So I say the truth. I always used to think that the truth is the truth. And as I grew older, I realized that there are different versions of truth. And so I'm going to tell you my truth, and you can choose whether to believe or not to believe. Instead of blinding you with science and thousands of papers, I will share with you some concepts and hypotheses, some of which are proven, some of which are not yet proven, but I believe and I know somehow that they're all right. So, as I say, I have actually been at this for over 20 years, ISBCS, and there were days when people would say that, you know, they hate you, they throw tomatoes at you, and they say it's unethical, not over my dead body, etc. But I think we're coming to some sort of acceptance. So I want to thank my fellow from Iran. He's professor there now in Tehran, standing on my right here at the top of the peak in Hong Kong some years back. He helped me with giving me all the literature up to date, and I had a quick glance to see whether there's been any change in concepts. And also Ahmed, another fellow, he's in the audience, and he's now in Leeds as a consultant corneal surgeon. And he has been great, and we still collaborate. And amongst the many things, there is this book, which if you were to buy, it would cost you a lot of money. But you don't really have to buy it, you just need to tell us, and then somehow we'll find a copy to you free of charge. Percival John Hay, a few words about the lecture named after him. He co-founded the North of England Ophthalmic Society in 1914, which was the beginning of the First World War, and he served as Honorary Secretary until his death, combining duties as President 31 to 32, so he actually held 2 offices. And the January Lectures was renamed after him on his untimely death in 1943. He was born in Switzerland from a Scottish father who became a professor at Basel University, and mother was from the Manchester area. So he returned to Scotland in Edinburgh to study medicine, qualified MBCHP in 1901, and 3 years later had his MD with high commendation. So then he had resident appointments at the Birmingham and Midland Ear and Throat Hospital and the Birmingham and Midland Eye Hospital. The eye hospital still exists, of course, but it's moved places, and eventually settled as an ophthalmic surgeon in Sheffield. So from what I've read, he was an excellent organizer, and he would be able to balance many plates and spin many plates and do different things, and he held joint meetings with the Midland Ophthalmic Society as well. And he worked tirelessly to serve ophthalmology, both clinical in his clinical and surgical duties, educating trainees and students and organization, as I said. And when he returned from serving at the war and a colleague was called up, he covered the duties as well. And it was concluded really that he worked too hard, and it contributed to his ill health and untimely death in 1943. So I think times have changed. I think in the olden days, if you're dedicated to your work, then that's fine. You know, that is your life. Life is your work. Work is your life. But now we talk about work-life balance, and sometimes if we think about it too much, I think we suffer. And I think it is okay to kind of bury yourself in work to a certain extent. So I thought I would show some flowers before I move on to the lecture. So just a historical note on cataract surgery. As ophthalmologists, we have always been taught to operate on one eye at a time. You know, from the very beginning when we enter first day training in ophthalmology, it's always one eye at a time. You know, for those of us who are a little more mature, of course, I mean, for the young ones, they are now walking in, and ISBCS is being done in some places. The take-up is not great. So historically, it was only cases requiring high-risk general anesthesia who had bilateral surgery done, or patients who required general anesthesia like Down syndrome with bilateral cataract. Also in cases for which the visual potential is unknown in either eye, for example, dense cataracts precluding the view of the fundi. However, and so I want to go back. Now, why do we do that? Because there is a fear of bilateral blindness. Okay, so it's a very deep, innate fear, and much of it is irrational, but it can be transferred. So I can transfer my fear to you in this whole room if I choose to, and you can also frighten yourselves if you want to think about it. But if you think about same-day bilateral eye surgery in other areas, there are lots of precedents, okay? So you have laser refractive surgery. Now, is it sight-threatening? Of course. I mean, you can get microbial keratitis in the interface, you know, some rare bugs which can cause you blindness. Lid surgery. What about if you get an orbital bleed causing you blindness? Or strabismus surgery, inadvertent perforation of your sclera, giving you endophthalmitis or even or retinal detachment. Same with VR surgery and intravitreal injections. But I understand that with intravitreal injections, it is quite accepted to inject both eyes on the same day nowadays. Now, the fear and historical things, the climate is changing, and there has been nice guidance on adult cataract surgery, which actually I don't think goes far enough, because, in fact, I think a colleague who chaired this particular committee, he didn't really believe in ISBCS, but I think he felt compelled to mention it, and he called it bilateral simultaneous cataract surgery. So in 1.6.3, the committee said people who are at low risk of ocular complications during or after surgery should be considered for ISBCS. And people need to have a general anesthesia for cataract surgery, but for whom a GA carries an increased risk of complications or distress. So the next clause discussed the potential risks and benefits of ISBCS with people, which should include the potential immediate visual improvement in both eyes. So tell them that actually it might be quite a good thing. And also tell them that it will not be possible to choose a different intraocular lens based on the refractive outcome of the first eye. Well, I don't think this is very important nowadays because of modern equipment and modern formulae. The risk of complications in both eyes during and after surgery that could cause long-term visual impairment, for sure, and we'll be talking about that. The likely need for additional support after the operation. Of course, for sure, because you have to look after the two eyes and eye drops going into both eyes. Now, the pandemic has changed things, and ISBCS is really much more accepted because of the scarcity of operating slots during the pandemic and the very complex self-isolation, testing and retesting before you can have surgery. It was just 2 years ago, and I think we've forgotten about it already, haven't we? But just thinking about it, it was a real hoo-ha that people had to self-isolate and staff had to self-isolate, for a week or two before any work can be done in pure green streams. So then the college and EUKISCRIS issued separate and joint guidances, and ISBCS was very much mentioned, and also new pathways as well. And the pandemic backlog is causing people to really consider ISBCS as an efficient way of delivering cataract surgery. So the concepts I wish to share with you in this lecture, the rationale for ISBCS, sorry for the misspelling, the prerequisites, the measures to reduce risk, some stakeholders' perspectives, some ethical and medical legal aspects, and how to improve uptake of ISBCS. The rationale, I think actually this is obvious really, that you only need one referral, one consultation, one preoperative assessment, and one visit for surgery, no period of binocular imbalance, and a few weeks later, one visit to the optometrist, one new pair of glasses, the health economics, the green issues and economic issues of reduced travel and time off for patient and carers. The carers often work and to reduce work output and so on. And as I said, COVID changed how we perceive this. The disadvantages, well, I used to think that there was only one disadvantage in that you're taking a risk with both eyes at the same sitting. But actually there are others. So there is double discomfort during surgery in that you've got to suffer the surgery double the time, okay, and then the post-op recovery is one lot, but it's double the discomfort because it's in both eyes. But on the other hand, you only have to go through it the once. And it is true that some patients may not be able to manage putting post-operative drops in their eyes by themselves, so they may need help. And there is a potential financial loss to surgeon and institution, which I will expand on in a moment. So what are the prerequisites? Now there is some overlapping in the next 3 slides, but it doesn't really matter. So who can have ISBCS? Well, obviously these will be grown-ups, not children, and they have to have bilaterally visually symptomatic cataracts. For beginning ISBCS surgeons, for sure that these risks should be low-risk eyes, and the patient should also be low-risk patients, and the operations should not be expected to be prolonged. Now, if you need a general anesthetic, then it kind of pushes you towards ISBCS, especially if it's a high-risk anesthetic, because you don't want to have to do that again. Prerequisites before offering bilateral surgery. So informed consent is very important. So I will expand on that a little bit more. Reliable biometry, mostly we have that apart from very dense cataracts, so you won't improve in your biometry if you just do the one eye. So that's fine, if you have to do an A scan, that's fine to do ISBCS. So then you've got to think about the team, the hospital, and the surgeon. Okay, so surgeon track record, hospital track record for endophthalmitis, and an experienced and knowledgeable team. And really, when you're doing ISBCS, you don't want to have a new member of staff in your team, unless they're just observing and not doing anything unsupervised or out of protocol, because it's dangerous. There doesn't need to be day one follow-up, but there should be some means for them to contact a hospital if the patients are in trouble. So just to concentrate on the team again, that the surgeon track record, the surgeon must have a good understanding of the concepts of ISBCS and how to make it safe. So as I already said, team track record, team cohesion, and hospital track record. As far as equipment and instruments are concerned, obviously you do need to maintain and renew your equipment, and the theatre, air conditioning and filtration, air change, all very, very important. So not to chop and change machines and IOLs frequently, because once you get used to something, when you change, there will be a learning curve, even for an IOL. So I've always thought, people should stick to the same IOL, maybe at least 3 years at a time. So trialing new items, again, be very cautious of that. Central sterilization, I think important, at least for hollow instruments like the phaco probe, because it's very difficult to clean and then sterilize the inside of the lumen. Now I put here, previously I thought, well, why don't we increase the use of disposable instruments? But actually, I'm not very much for this now, because it's not sustainable to keep throwing things away. Audit is important, so you've got the various outcomes, and you've got PROMs as well. And amongst the complications, I think endophthalmitis, cystoid macular edema, and PCR are the most important. So of course EPR is great, and you've got the National Ophthalmic Database as well. But unfortunately, for most EPRs, they also slow down your turnover. I mean, it's okay if you've got somebody filling in the form for you, but that's not always possible. And to have to fill in forms which take longer than the operation is not very clever. So what are the measures to reduce risk of something going wrong with ISBCS? Well, there are 3 steps. Firstly, case selection. Secondly, the option not to proceed with second eye surgery if the first eye has not gone completely well. Thirdly, treating each eye as an independent operation. So in the small print there, I will have a bigger slide on that, so don't worry about trying to read the very small print. So which are the high-risk eyes? And you all know about these, because we know about risk stratification started by cardiac surgeons, but we know about it now, so we know about high-risk eyes and high-risk patients. So risk of infection, so the patients with untreated blepharitis, blocked tear ducts, diabetic patients who are immunosuppressed, patients who have iodine allergy, and of course you can do a patch test before you use iodine in the eye, patch test on the skin before the date of the operation. Well, there's risk of corneal decompensation, any lenticular abnormalities, so exfoliation, subluxation, vagonesis, previous trauma, risk of glaucoma, risk of retinal detachments, risk of biometry error, and risk of intraocular inflammation. So here are some pictures of such cases, like dense brown, stuck down pupil, small pupil, pseudoexfoliation, Morganian cataract, and so on. So, I mean, there are people who will do these bilateral on the same day, but I think as a beginner bilateral surgeon, best avoid it really. So now, how about reducing the risk of bilateral infection, inflammation, or contamination? So traditionally, we do re-glove, re-gown, re-drape, and during draping, exclude the lashes, make sure that there is plastic underneath both upper and lower lids, and the drape should stick to the bridge so that the operative field is not in communication with the nose breathing in and out. Slight face turn to drain away the fluid, and all members of the surgical team wear face masks. So a new trolley of instruments for the second eye, one phaco set held back from the previous week, if possible, and that's a good good tip for only eyes as well, because that whole batch of sterilization has already been tested on natural human guinea pigs. I used to think that IOL should be of different power, but actually that probably is not necessary because they have different batch numbers anyway. So anything entering the eye, for example, your balanced salt, OVD, anesthetic, antibiotic, etc., should have come from different manufacturer or bear different batch numbers. And I think it is a good principle to reduce intraocular substance for fear of contamination or incorrect dilution or what have you, damaging the endothelium. Having said that, it's not the end of the world. You know, if you get corneal decompensation, you can always go back and do a DMAC. Nowadays, a very, very successful operation. Now, the option not to proceed with the second eye. So what would trigger not going ahead with the second eye? Well, I think there will be different criteria for different surgeons. But for me, I think a lengthy operation, vitreous loss, or any significant PC, posterior capsular problem. And this is because when you have these problems, then you have a much higher risk of endophthalmitis, cystoid macular edema, and retinal detachment. So that is why, and it is now accepted, that is called ISBCS, so it's immediately sequential and not bilateral simultaneous, because it is actually one after the other, and you can also change your mind. It's not a ballistic decision. This is interesting. I found that different people do different things when it comes to which eye to operate first. In my practice, it is usually the eye with the worst cataract, with exceptions. Say if there was a lot of asymmetry and the worst eye is actually a nasty one, then I give myself a better chance by operating on the easier one first. Now you may say that, well, I'm cheating the system, but that's what I do, and they get a better chance of having both eyes completed, because there will be a higher risk of complication, higher rate of complication with a high risk eye. Now I have come to find that there are some surgeons who will always operate on the right eye first or the left eye first. Well, there is some logic in that, because it may be easier for the entire team that it is always one eye first. Usually it seems people choose the right eye first for whatever reason. Choice of anesthesia, I think the standard should be local, in some cases GA. I think the sharp needle techniques, I mean, this is a reincarnation of an old slide. I think sharp needle techniques, people don't really do that anymore. And I say avoid intracameral, I mean reduce the amount of intracameral substance used when you're operating on both eyes at the same time. And I'll go into that a bit further later. If we think of the catastrophic complications of cataract surgery, we used to worry about expulsive hemorrhage. But I think if you've got a small self-sealing keyhole wound, it should be self-limiting. And also if that happens, you can always not operate on the second eye. Bacterial and fungal endophthalmitis, that is one worry, is the major concern. But actually, there is another major concern that people don't think about very much, and that is cystoid macular edema, because you can get bilateral cystoid macular edema even when the operations have gone very well. And CMO does not necessarily resolve altogether, back to the original situation. So there could be irreversible visual loss. So I want to introduce you to this concept of conditional probability, and that is to say that the two eyes are not independent. So that's why when you're doing a scientific study, you don't use the contralateral eye as a control. They both belong to the same person, so the two eyes will have the same genetic makeup, the same sort of ocular environment, and the same sort of person who may be very careful with their eyes and keep them clean and not touch them. Equally, they could be people who rub their eyes and touch their eyes all the time. So therefore, the concept of conditional probability tells you that if a complication happens to one eye, it is more likely to happen in the other eye as well. So my surgical practice is, for the first eye, topical and intracameral anesthesia, clear temporal corneal wound with a low threshold for suturing, so it's watertight and slightly resistant to very minor trauma, and intracameral cefuroxime. And then I would put a gel net, pad and shield, and then I would remove that once the second eye has been done, so that patients would be seeing through their first eye through a clear shield, having had topical and intracameral anesthesia. When it comes to the second eye, I usually use a subtenons and a scleral tunnel. So I would have taken off conjunctiva, and then I have access to the subtenon space already, and then I carry on with the scleral tunnel. So they can either, for the second eye, get aprocam or just subconjunctival cefuroxime, a very big dollop, which means that it leaks out in the next 12 hours and keep the intraocular concentration to be very high. And with that, dexamethasone and lidocaine to reduce the discomfort. And that eye will be padded till the following day. So now I gather that actually there are very few people who do scleral tunnels. I do know that, but it is very strong. So if you have a scleral tunnel and then the eye has a major trauma and the globe ruptures, it will rupture at a usual place around just behind the insertion of your rectus muscles, and not the scleral tunnel. The scleral tunnel will be fine. So you have that physical strength, and it does provide you with a lower risk of infection as well compared with a corneal wound. Now the subtenons is to allow for the second eye syndrome. Now you may or may not have heard of the second eye syndrome, and you may think that I've just made it up, but actually I haven't. So the second eye syndrome is that patients always feel the second eye cataract surgery more than the first. And it's the same whether it's immediately sequential or delayed sequential. The mechanism is unknown, but the reduced anxiety following the first eye operation, so they expect a lot of discomfort and find that it's not so bad, and the guard comes down, and then they're more attentive to the discomfort it created for their perception with the second eye. So even if you warn patients that you will feel the second eye more, they still feel it more. There's no way out. So I think the subtenons is quite a good thing. And then there are theories such as drug tolerance to the anesthetic, analgesic, or even anxiolytic. And there is another theory that it gives rise to sympathetic irritation, and then the second eye is kind of got a heightened sensation. So let's have a look at the different stakeholders' perspectives. Well, I will concentrate on the patient and the provider, but later on in other slides I will mention the other stakeholders. So these are the stakeholders, really: patients and carers, surgeons, team members, nurses, optometrists, the hospital management, commissioners, and the whole health economy, society itself, and sustainability. So for the patients, obviously their journey is much simplified because everything is cut by 50%, and they get rapid and full visual rehabilitation. And studies have shown that if you separate the two eyes, they only reach the same visual rehabilitation 1 month after they only catch up 1 month after the second eye operation. Whereas if you do the two together, then very quickly they get the whole benefits. And studies have also shown that by day 1 or day 2, then patients are already seen quite adequately following ISBCS. So you don't have to worry that they're not seeing because you've operated on the two eyes on the same day. It will be quite a short-lived not seeing clearly. Well, the cons that you're taking a risk with both eyes at the same sitting. Now you could argue it would be roughly the same risk if you separate the two events onto separate days, or whether it's minutes or days or months apart. However, it is true that you can also decide not to have the second eye if your first eye develops a problem post-op but not during surgery. So that there is that. Okay, so bilateral recovery may be more arduous, especially if bilateral CMO should develop. And of course, there is fear of bilateral blindness. You can assure and reassure, but you still have to mention the possibility of both eyes losing sight irreversibly. So people will be frightened. Now, what about surgeon and optometrists? Well, the process if you believe in this, you're providing the best care for patients. There is increased efficiency and your reputation may be enhanced. But of course, if something goes wrong desperately, then your reputation will not be enhanced. You may, so if it's enhanced, you might get a busier practice, but when it's not enhanced, if it ever happens, then your practice could not be busy. And so there is a reputational risk, for sure. So I think you need to be very careful what you do, and everything needs to be documented. Now, the reduction of earnings, we'll come to that in a moment when we talk about the financial aspects of ISBCS. So let's have a look at ethics and medical legal aspects. Well, this workshop was a long time in the making, and finally I managed to assemble some 30 people, and the college was very gracious to let us use the council room, and some of us in this room were there in 2019, and we debated for 3.5 hours to get answers to some predetermined questions. So who are these people then? Well, there were 3 ethicists, there were religious persons from the Catholic Church, rabbi, imam, 2 lawyers, 1 health economist, the nice chair was there were college officers, there were surgeons for and against, and there was 1 optometrist representing the College of Optometrists, and there were many patients and lay persons, including the independent lay chair. So if you really have nothing to do, you can watch all that 3.5 hours on my YouTube channel. But I've realized that actually it hasn't really had many views. So what are we talking about when we talk about medical ethics? And it's quite amazing, because medical ethics is the same throughout different cultures and throughout the world. We're talking about these 4 pillars of autonomy, to do good, not doing harm, and justice. So by autonomy, we mean the patient should have a choice. They should really understand what is presented to them. The surgeon should also have a choice if they don't want to do ISBCS, but they should not have a choice not discussing ISBCS with suitable patients and not referring them to a colleague who does this sort of procedure. So in terms of social justice, basically there is only so much money in the world and in any economy and any region. So if you reduce the healthcare costs, the same money can do more good to more people, but don't expect that the money you save will come back to ophthalmology. Well, it doesn't have to, because the money is supposed to do good to everybody. But of course, we all have to fight our corners, but it's good to be efficient and conserve resources. Well, I think we've talked about that already. The patient should be given a choice. Now, I don't know about you, but actually I find that the concept of informed consent, I have great difficulty with that, because I think the more you explain, the more they don't understand. So I don't know what you do when you ask for consent for cataract surgery. I just say that, you've got cataracts, this is to help you see better, but it can go wrong, and the worst case scenario is an unsightly, blind, painful eye. And I say it quite quickly, and then and then they say, okay then, so they sign. But can you imagine, you're trying to explain the concept of ISBCS. So at the end of the day, it's down to us to guide patients, and all of us will have biases, subconscious or unconscious bias, but it's a matter of keeping things in check. And I'm pleased that ISBCS is no longer taboo, although I think it is still illegal in Vietnam. Now, in terms of whether the law will support you, it is being done, so you can offer ISBCS according to lawyers. But if something goes wrong, you have a lot to answer for. So what he says is document your discussion. And again, we can't force surgeons not to go do ISBCS if they don't want to. Okay, but they have to discuss with patients. We've talked about this already. Now, we actually wear two hats. Okay, so when we're seeing a patient, their concern is our prime concern, but we're not actually seeing patients. We also have a duty to society to conserve funds. I think we talked about that already. There's only so much money. In terms of the Catholic Church, the Catholic faith says that we should give preference to the poor and helpless, and this includes conserving funds. Well, just a very, very few slides about sustainability. Okay, so we use a lot of stuff. The major elements creating greenhouse gases are transport, waste disposal, and single-use instruments. So that I try not to use single instruments, and also I'm reducing the number of instruments I use to very, very little, as much as possible. And I don't know why they open the whole set, because really I just need a few things. In fact, fewer than what you see down there. Now, this is my previous place of work at the Sussex Eye Hospital until they retired me in December. Look, in one day operating, we have created all these bags of rubbish. But if you have the same volume, and you see in some places in India, they would hardly have just one bag, for the same amount of activity. So I think we do create a lot of waste, and we need to be mindful of that. And I just think that, I'm thinking, do we really need to change our gown? Maybe just our gloves in between the two eyes, I'm thinking. So I want to also introduce this, which a lot of people don't really think about. The children think about this, intergenerational justice. So it's one form of social justice, and this is mainly defined as a form of distributive justice, where present generations hold an obligation towards future generations, not to pursue policies that create benefits for themselves, but impose costs on those who will live in the future. So I'm just thinking, if we have everything good for ourselves, what about our children and grandchildren to come? I mean, hopefully there will be a future for them. There are other areas that I will quickly cover. So people worry about creating two queues, that there are lots of people waiting for the first eyes, whereas some people, you go and operate on both their eyes. Is that not unfair? Well, and is it not unfair? Some people travel business class and some people travel, at the back of the aeroplane. Well, the thing is, actually, thankfully, it is not like that, because ISBCS, you're operating on fewer patients, but you're operating on more eyes per list. So after an initial hump, then the waiting list will actually go down. Training, again, now a very hot topic, because over half the cases are going to independent sector, and we have this uncomfortable relationship with the independent sector that some of us actually go and work there, and then we pretend when we come back to the NHS, then we pretend that they're different people. So what do we do about training then? Well, actually with ISBCS, there's nothing to stop trainees operating on the second eyes. They are just second eyes. They're the same second eyes as any other second eye, okay? And the first eye is the first eye, and if it's not complex, then a trainee can do it. So a senior trainee can operate on both eyes of an ISBCS, as far as I'm concerned. Also, there is something uncomfortable, and that is, there are some surgeons who can do thousands of operations per year. And then there are some surgeons who are competent, but not really that slick. Now, what are we going to do? You know, some people say, well, not everybody have to operate, and we can concentrate on fewer surgeons. That is just one very uncomfortable thought. Now, theatre nurses, we are in the middle of surveying theatre nurses. They don't really like ISBCS very much because you have to set up the different trolleys and write down all the batch numbers and so on. So it would be of great help if manufacturers would do pre-packed instruments. So you have left eye packs and right eye packs that you just pull off the shelves. That would be very useful. So how safe does it have to be before it's adopted? There is great difficulty with doing a randomized controlled trial because the risk of bilateral endophthalmitis following ISBCS is present, but is very, very small. So you would need to do millions of cases, and that proves to be just too expensive to do. It's not going to be possible. So the consensus at the end of the meeting was that you need to go ahead gradually and see what happens. So the work which is done in Leeds that is being presented, that's really wonderful. That we'll see how the culture changes and how the service goes. There is also worry that if you do one and then the other a few minutes later, you might be doing some unnecessary second eye operations. And I think this is a valid criticism because there'll be some, if you had delayed the second one, they might say, well, actually, I'm quite happy with this. And the second one may be delayed for a long time, or maybe never done, until the good Lord takes them away. So this is a valid criticism, but I think if you choose your cases carefully, then we will not be doing too many unnecessary second eye operations. So now, what's holding back the rollout? Because actually the uptake is very poor. It's still very poor. Well, fear we talked about. So the surgeon may be scared, colleagues may be scared, and they scare one another, and patients can be scared. And I have had more than once the patients lined up for immediate sequential bilateral cataract surgery, and then one nurse, just thinking it was small talk, oh, you're very brave. That's it. That was it. And so then say, oh yeah, I'm just going to have one eye done. But actually that's quite a hoo-ha because everything is prepared and it's terrible. I think you have to be very careful what you say to patients and not allow your irrational fear to transfer. So I've mentioned about these uncertainties already. We don't really know the true risk of bilateral endophthalmitis. Now let's say, okay, so if it's 1 in 1,000, that's quite a high estimate actually. If you've done the operation carefully and used antibiotic, it's less than 1 in 1,000, but let's say it's 1 in 1,000, the risk of both eyes getting endophthalmitis will be, the risk is higher than 1 in a million. I normally say 1 in 200,000 to allow for a bit of conditional probability. CMO, I think that is worthy of research, and maybe we also give them some non-steroidal as well to help fend that off. Biometry error and refractive surprise, I don't think many people worry about that anymore. So in terms of money, the tariff on the NHS of ISBCS is not double delayed sequential bilateral surgery. Now in the past, in the Brighton area, I've managed to negotiate 1.95 tariff with commissioners, and I think that's actually very good because there is a lot less work for the hospitals to do as well when the patient comes in and gets both eyes done. So 1.95 is very good. I mean, I would accept 1.9 or even 1.85. Now for those, for block contracts, it's not a problem. Now, insurance reimbursement is also a problem in the private sector. You could say, well, I don't really care what your reimbursement is. My fee for one eye is that much, and my fee for 2 eyes will be double that, and you've just got to pay me the shortfalls or a shortfall. However, it's not so easy because the younger consultants, when they sign contracts with the insurance companies, they can only be fee assured, which means that there can be no shortfall. And if, when they operate on both eyes together, they don't get double the amount when they compared with when they separate the 2 eyes, so they would be disincentivized to do ISPCS and incentivized to inconvenience the patient to come back twice. Now, it's interesting though, the private hospitals or even the private wings of NHS hospitals will charge much less per eye for bilateral cataract surgery compared with unilateral cataract surgery, which means that there is actually an opportunity for self-pay patients that if they are done together, you are actually incentivized because you will get a more fee for yourself if you quote a fixed fee, a package for your patients. So the way forward, I mean, how dare I use the way forward when John Buchan is here? Anyway, I will just say these are my thoughts. I think CMO really is worthy of study because I think that's a very important area apart from endophthalmitis. I think we need a stronger recommendation from the Royal College of Ophthalmologists, and I will work on them. I think we need to find out what people are really so worried about. So you get an idea, but actually, unless you do formal surveys, you don't really get the complete answer. So different authors have looked at different areas, and we are also, my group also looking at different areas. And I think when we find out what the blocks are, then we need to educate the general public through media and the journalists, patients, optometrists, nurses, and ophthalmologists. And we need to educate the commissioners and insurance companies as well. And then have, we used to have mixed lists, and now we have pure cataract lists. There should also be pure ISPCS lists, and that should make the flow much easier. Left and right eye packs from manufacturers, and then with after effecting a major culture change, then it should run more smoothly. You may not imagine, but there is actually a whole book on ISPCS, and I contributed to this, to the chapter in ethics, and I wrote the afterword for this book as well. So, we're back to truth again. So, I think if you're interested in truth and you want to tell people that you're telling the truth, first you need to lie to yourself. I'm not saying that that's me, okay? There are 2 people in this picture. I want to thank the organizers. It's been lovely speaking here and traveling up and enjoying fellowship with you, and it's a real honor to deliver this year's Hay Memorial Lecture. And of course, when you're up here near York, you should try York beer as well. And here are my email addresses. I don't think there will be much time for questions, and usually we don't take questions. But I mean, actually we do have about 10 minutes. If people have burning questions, I'm happy to answer. Thank you.
Good afternoon, Jennifer Tan, Sheffield. Thank you very much. It was a really exciting talk. We go through ECCE, and then we go through phaco. We go through temporal approach, superior approach, and then we go to temporal approach. We go to suture and sutureless. I think we're going through a rather exciting time, but we're going through it with great trepidation and resistance and reluctance, and it's trying to shift the whole engine. My question to you is, would you consider doing bilateral sutureless clear corneal incision cataract surgery for your ISBCS?
As a routine,
Yes.
I think eventually I will do that because the nurses really hate sclerotunnel, and you know we are actually going to smaller and smaller incisions, and also if you do heel down and point up when you're doing your incision, you can make it longer as well, and it can be very, very secure. Yes, I would do that, but I mean I wouldn't do that in somebody who keeps rubbing their eyes. In fact, I mean for people who keep rubbing their eyes, I would only do one eye at a time. But yes, I will. I think you know it's an evolving situation, and we learn to cut corners. But if we cut too many corners, then we're going to be in trouble. So it's a balance.
I appreciate that. Thank you.
Thank you.
I mean, in terms of your consenting, we also are very faced by some resistance, but I find using the word bog off, buy one, get one free, actually works rather well with some patients. Also very encouraging.
No, nothing is free. I'm sorry. You know, I'm sorry. I charge a 5,000 per eye, so it's going to be a 5-figure for 2 eyes. I'm sorry.
I'm sorry. I only do NHS work, so I apologize.
No, I've done 40 years of that, so. Yeah.
The other thing was I'm very encouraged by your thoughts about training. And the challenges that we have now with the independent sector. The only straightforward cases we do are your ISBCS eyes. So you can imagine that these are the ideal opportunities for the trainees. But my angle was I did start with them doing the first eye and you doing the second eye, but your way around with me doing the first eye and the trainee doing the second eye. And the patient found that really quite arduous because it just say, why did it take so long to do a second eye? So now I actually switch that the trainee does the first eye, and if anything goes wrong, then I have a reason not to proceed. So I think there are different ways of ways of doing it. So there's no right and wrong. I accept that. But there is an opportunity there for the trainees to do that case, for example.
Yes.
So these are just really thoughts.
You're absolutely right. As people say, there are many ways to skin a cat, and you know, and swing. Anybody else? Anything else?
Hi there. Thank you very much. Just a quick question. One of the problems I found when trying to introduce new concepts into the NHS is that the barriers immediately go up. And it's the little things that we don't know about that everyone wants answers for. A bit like you saying you put a shield over the first eye and then take it off at the end of the operation. So it's the protocols that management want in place describing every single aspect of this type of surgery. So that's the hard part I suspect that many hospitals will have. So is it possible to share those written protocols? Because whenever I've asked people who say that they do this type of bilateral surgery, they always say, yeah, I can give you that, no problem. And 2 years have gone by and they still don't give it because they actually haven't got anything written down.
Oh, you mean they lied to you?
Yeah.
Look, I got 3 email addresses there. You can write to all 3 of them. So,
it was an excellent talk. Thank you, Prof. Liu. So I'm the trainee from Sheffield. So in Sheffield, over the last 2.5 years, we have done over 300 patients who had ISBCS. And then I think you touched on this, and we had 3 bilateral CMO.
mm-hmm.
They do resolve eventually, but I think it was quite scary for both patients and surgeons. We know from the ESRS pre-med study, if we give non-steroidal anti-inflammatory drops, it reduces the risk of CMO, but those drops are not completely risk-free, and then they are adding extra cost as well. So what's your advice to reduce the risk of CMO for those patients?
Okay, so I don't actually routinely use an NSAID eye drop, and if they have any significant epiretinal membrane, then that's different. Okay, so I mean, even for those, I would still offer ISBCS following discussion, but they would get 8 or 12 weeks of eye drops and NSAID. Regarding there is something else as well. I know you said your 3 cases resolve, but some don't. So I think that's the worry. Until it resolves, you don't know whether it will resolve. And also, in terms of Aprocam, there is some suggestion that if you give more than 0.1 mil, and there may be a higher risk of CMO. So be careful of that. Okay.
Thank you very much. Thank you, Chris. And can we give Chris another... Thank you, everybody. Can we reconvene at 3:15, please, for the Cataract Symposium?
Can you take one for me again? Oh, my own picture.